Hello, everyone. My name is Emily Brazier. With me today is Jessica Getzo, Victoria Taylor, and Abby Ferris. Today, our panel discussion will be on access to care for individuals with substance use disorder. The multifaceted concept of access to care for individuals with substance abuse disorder has been a controversial issue in the current political atmosphere, both professionally and personally for individuals. Ultimately, there is a strong body of to care for individuals with substance use disorder while addressing the concerns of findings that have been weary of reform. To start the discussion is Jessica Getzo.
So first, we really wanted to discuss the viewpoint of why access to care for substance use disorders is necessary and really emphasize the current policies that are expanding access to care. So supported evidence indicates that one fundamental way to address racial and ethnic disparities in healthcare is to increase the number of people who have health insurance coverage. So the lack of full continuum of services provided by Medicaid plans, as well as communities of color facing additional barriers to treatment, would be an example of this. Insurance coverage for substance use disorders is becoming more robust as a result of the Paul Wellstone and Pete Dominici Mental Health Parity and Addiction Equity Act and the Affordable Care Act. The Affordable Care Act also requires non-grandfathered individual and small group market plans to cover services to prevent and treat substance use disorders. These are the two current policies that we really focus on in this slide. So these two current policies offer expansion and access to the accessibility to services and care for individuals who are struggling with substance use disorders or mental health disorders. And as seen with the large number of individuals who struggle with substance use disorders in our country being over 21 million, the access to care for services and treatment on a continuum is really imperative. In our next viewpoint, we discuss the pushback from the public or community on access to care. So the real social issue that exists amongst the conversion and policy issue that is treatment and access to treatment for individuals struggling with substance use disorders is the stigmatization that affects the expansion as well as accessibility to necessary care and services, which we'll further expand on in a later slide. There are many effects of substance use disorders, not only on the family, but also within society as a whole. And these problems really emphasize the needs for clients in treatment to address these domains and their ongoing recovery. So the pushback from the public and or the community on the access to care in regards to this policy issue may be that there is already a great deal of funding being allocated to services such as treatments for addiction, medical or psychiatric disorders, welfare dependence, unemployment, as well as funds to the criminal justice system and various other social systems that citizens already believe their funds and tax-paying dollars are being allocated to. So there is a common groupthink amongst those in societies who do share negative viewpoints on SUDs, which is referred to as stigmatization, which ultimately does affect the accessibility to services, which, as I previously mentioned, will be discussed further in a later slide. Next, we review the viewpoint of adverse unintended consequences of integration of settings-based interventions. So here there are various unintended consequences that could stem from the integration of early on intervention treatments for substance use disorder into state local policies. So according to the United Nations Office on Drugs and Crimes, as well as the World Health Org, there are various setting-based approaches in which awareness and early on prevention are geared towards lessening the risks and risky behaviors that could lead to SUDs. Although in the same approaches, there may be unintended consequences that step from the prevention and awareness efforts of substance use disorders and treatment. So some of those unintended consequences that could be increase of use as well as an increase in risky behaviors due to encouraging the association and encounters amongst a group of individuals that are already at risk. And this was explained through a current study and research that we reviewed in this slide that was conducted by authors Ranky Bilias, Eva Refuse, and Jane Stradil, who are all chairs in the Public Health Services Research Institute for Medical Information Processing, Biometry, and Epidemiology, in which they found that unintended consequences did stem from integration, prevention-based treatments, and primarily adolescent to young adults. And now our team member, Tori, will discuss and review the negative impacts of stigma around substance use disorders.
Thank you, Jess. So In the viewpoint of efforts that work to destigmatize substance use disorder to the general public, to encourage access to care, I included the slides on the negative impact of stigmas around substance use disorders and shifting the paradigm on stigmas around substance use disorders. So stigma can be described as a set of negative and unfair beliefs that a group of people have about something. It can be associated with the lack of knowledge, lack of understanding, or fear. So for individuals with substance use disorder, stigma may stem from inaccurate beliefs, the biggest being that substance use disorder is a moral failing or choice. Stigma surrounding people with substance use disorder can include that they are dangerous, unable to complete treatment or recover, unable to live a healthy life, and that they are at fault. So along with the effects listed on the slide, I also wanted to touch base on treatment as well. So regarding treatments, many medications that are used to treat substance use disorders, so along the lines of opioids, they're underused in part due to the stigma and misunderstanding about their role in treatment. So there's often a viewpoint that individuals who are using the medication as treatment are not actually improving or in recovery, and they're not completing treatment at all. So when it comes to shifting the paradigm on stigmas around substance use disorders, it's important to understand that any effort to address the access to care of substance use disorder must include action to reduce stigma. A few ways we can reduce stigmatizing behaviors towards substance use disorder include knowing the facts, educating yourself and others, being open-minded, being aware of your attitudes and behaviors, supporting other individuals, and using person-first language. So person-first language, it is proven to reduce stigma and improve treatment. It is non-judgmental, neutral, and purely clinical. It also does not define a person based on any medical disorder. So by choosing language that is not negative, we can dismantle any negative stereotypes. And you can see on the slide, I included examples of this language that can be seen. So it includes words not to use, so words to avoid, and then the alternatives of person-first language, that words you can include. And then now Abby will discuss why the access to care policies for substance use disorder are acceptable.
So as Tori mentioned, focusing on the current access to care for individuals with SUD, there is a viewpoint that access to care is already acceptable. So this is due to the current policies and treatment. So treatment can range from outpatient treatment, intensive treatment, as well as residential treatment, even inpatient hospitalization. Considering treatment programs, there's a few different models. So that can be psychological, medical, and socioculture. And treatment in the outpatient world can look very different. So it could look like cognitive behavioral therapy, family therapy, and motivational interviewing. And with residential treatment, it can include short-term therapeutic communities and recovering housing. Due to this vast range of treatment options, this is the viewpoint that they build, that access to care for an individual with substance abuse disorder is already acceptable. In addition to that, there's also current policies. So as highlighted in the presentation, there is 3 federal policies that are already in effect to address access to care for individuals with substance abuse disorder. So these include the Support Act of 2008, the Comprehensive Addiction and Recovery Act of 2016, as well as the Mental Health Parity and Addiction Equity Act of 2008. Each of these policies work to address access to care for an individual with substance abuse disorder. So in regards to the Support Act, according to the Substance Abuse and Mental Health Services Administration, the legislation includes provisions to strengthen the behavioral health workforce through increasing addiction medicine education, standardizing the delivery of addiction medicine, and expanding high-quality evidence-based care. In addition, it covers addiction medicine. Additionally, the same entity highlighted that the Comprehensive Addiction and Recovering Act, referred to as CARA, is expected to both not only fund treatment programs, but also already boost prevention efforts as well. And it also authorized over $181 million a year to be appropriated for these efforts. Lastly, on the Mental Health Parity and Addiction Equity Act, this boosts insurance coverage in regards to those with substance abuse disorder and other mental health disorders as well, to ensure that deductibles, copays, and out-of-pocket maximums and treatment limitations for substance abuse disorder are comparable to general medical coverage, which also boosted access to care already. As one can note from all of these treatments and policies, there's already an acceptable access to care due to some people's viewpoint. And now Tori will focus on why the other viewpoint shows that it's actually a limited range of treatment.
So as Abby touched base, even though access to care policies for substance use disorder are acceptable, there's supported scientific evidence that indicates that the traditional separation of substance use disorder treatment and mental health services from mainstream healthcare has created obstacles to successful care coordination. So we also often see that individuals with substance use disorders often access the healthcare system for reasons other than their substance use disorder, maybe being mental health, or other chronic diseases that may be in relation to substance use disorder, but many do not seek the specialty treatment for SUD in general, and that they are often overrepresented in many general healthcare settings, so which results in the limited range in reaching these individuals who actually do need the access. And then Abby will now kick off our discussion on harm reduction.
Harm reduction is a newer treatment modality for individuals with substance abuse disorder, and it's also been a controversial treatment. So one viewpoint is that harm reduction is actually harmful to the greater good. So with this, following the funding of President Biden's American Rescue Plan in December of 2021, the Harm Reduction Grant Program was announced through the SAMHSA. Soon after this announcement, controversy from the general public became apparent through blog posts, news outlets, and even a few protests. The main reason that the viewpoint was that this harms the greater good was due to the fact that there is currently a federal statute that strictly prohibits the usage of federal funding to support the purchasing of syringes and needles, according to the Johns Hopkins Bloomberg School of Public Health. Despite the fact that between May 2022 and April 2021, over 100,000 individuals died of overdose, the general public does not support the use of harm reduction as the answer to this problem. In regards to the current harm reduction grant, the general public has raised concerns regarding the use of funding, and this will need to be addressed in order to truly understand how harm reduction may benefit the greater good in the long run. Now, Emily is going to focus on the other viewpoint of how harm reduction is an effective modality.
So harm reduction can actually look different depending on the topic. Harm reduction can look like wearing a seatbelt or even wearing sunscreen or taking birth control. However, harm reduction in relation to substance use incorporates a spectrum of strategies that include safer use, managed use, abstinence, meeting people who use drugs where they're at, and addressing conditions of use along with the use itself. Because harm reduction demands that interventions and policies designed to serve people who use drugs reflect specific individual and community needs, there is no universal definition or formula for implementing harm reduction. The National Harm Reduction Coalition is an organization that creates spaces for dialogue and action that help heal the harms caused by racialized drug policies. There are 8 guiding principles that guide harm reduction, and on the next slide, we'll go over that. They highlight accepting people for better or for worse, despite their use. They understand that substance use is complex and a multifaceted phenomenon that can look different between each person. They strive for focusing on the well-being of the individual instead of the cessation of all drug use. It says that harm reduction is non-judgmental and non-coercive. It allows the individual to have a say in the creation of the programs. It empowers people who use drugs through support and recognizes that there are several factors and inequalities that affect people's vulnerability and capacity to change. And lastly, harm reduction does not attempt to minimize or ignore the real and tragic harm and danger that can be associated with drug use. Harm reduction is proven to be successful. Harm reduction in action in terms of substance use can look like programs such as the Drug Overdose Prevention and Education Project, or the DOPE Project. The DOPE Project is the largest single city naloxone distribution program in the country. We've trained more than 13,000 people in San Francisco on how to administer naloxone to reverse an otherwise fatal overdose from opioids to the National Coalition of Substance Use. The DOPE Project supplied naloxone to the community and reversed around 2,600 overdoses in 2019. So it's proven to be very effective. For more information on harm reduction in action and similar projects all across the country, you can scan the QR code to the right to access the National Coalition of Harm Reduction and go to their harm reduction in action. To finish it up, I'm going to give it to Abby.
So thank you everyone for listening to our presentation thus far. We hope from this panel discussion that you took away that substance abuse is a real disorder and a medical disorder at that, and that reform to access to care is needed. And there is a way to reform access to care while addressing the concerns of the greater public. It's important to emphasize reliable, affordable, and accessible access for individuals with SUD while engaging and messaging to the public that the price for treatment outweighs the long-term financial impact without treatment, as well as efforts that work to destigmatize SUD to the general public and encourage access to care. Additionally, policies that build on current legislation to promote treating the whole person in regards to SUD is critical to this movement. And lastly, programs that are creative and meet the individual where they are, such as the harm reduction model that was highlighted, while incorporating access to states to use the funding most appropriately and effectively, is also important. Thank you for listening.